Good afternoon, everyone. Hope you had a good afternoon session. We've been listening to the lectures. So what I'm going to do, of course, needs no introduction. Gianfranco Butera, and to his right is Muhammad. And I'll give the microphone to Muhammad to give us the history of this patient.
Oh, which I think is
Carmelo. I apologize.
It's case number 14 in our booklet. Is it right?
Yes, it
is. Go ahead.
Okay, go ahead, please.
So this is a 6-year-old boy with a weight of 32 kilos and a diagnosis since infancy of a perimembranous VSD, completely asymptomatic with normal growth. He's got a harsh murmur, no signs of heart failure. Next, please. The chest X-ray shows a normal-sized heart, basically, but on echo, next, please. We have a perimembranous VSD with a high velocity left to right shunt and an end-diastolic diameter of the left ventricle of 47 millimeters with a Z-score of plus 2.5. Next, please. So as you can see, there is a small aneurysm, small fibrous aneurysm with left to right shunt size is about 5 millimeters. Next. And we were a bit concerned about the proximity of the right coronary cusp to the defect, but we'll move on to the transesophageal echo pictures.
So let me introduce also Dr. Ludomirski. Achi is from New York, and he's going to go ahead and tell us about the echo finding by TE. Achi.
So thank you, Z. As we can see here, and I agree with Carlo, practically the transesophageal help us a little bit.
Can they see the echo images? Yeah, thank you.
A little bit. So this is the equivalent of four-chamber view. You see the outflow tract and the aortic valve, and the VSD is in this area. We'll clear it up a little bit better, as you're going to see here. Little aneurysm of the atrial septum. We measure it, and we got measurement between 5, 5.5 to 6. As you can see here, here is measure 5.19. There is a little aneurysm, exactly as Carlo described before, equivalent to a short axis, nice aortic valve, very, very mild prolapse of the right coronary cusp into this defect. As you can see here, no significant AI in any way, shape, and form. And another view of the same. Then we went to the 90 degrees to that. Again, you see here the aorta here, left atrium, left ventricle, interventricular septum. And I think we all can appreciate the ventricular septal defect sitting practically under the aortic valve, perimembranous, and with color. And the measurement here was again about 5.62. We did some 3D that we'll show you in a second here. And you can see the aortic valve is right here and the defect just sitting under the aortic valve. Again, aortic valve here and the defect just sitting right here under the right coronary cusp.
Great.
One more thing, we'll show the sheath going across. We'll go directly to the end, and you can see here in this view a sheath coming from the right atrium into the tricuspid valve across the VSD into the left ventricle.
Great, thanks a lot, Achi. So as you can see that this is a perimembranous ventricular septal defect very close to the aortic valve. So our patient is about 30 kilograms. We got access in the right groin. Initially we started with a 7 French in the femoral vein and 5 French in the artery. We did full hemodynamic evaluation, which was normal basically. And his QP-QS ratio was 1.8 to 1, if you believe this. But nonetheless, as you saw by the transthoracic echo, the LV is volume overloaded. So we did the hemodynamics, and we did the first angiogram. Can we show them the angio, please? There's the angio, as you can see, in the left ventricle. You can see that actually I was a little bit surprised when I saw the jet. So there's two kind of things. The jet itself measured about 4.25 millimeter, and just proximal to the jet plate, stop right there. No. Yeah, that's good there. So you can see that there is two opacification. One which is the jet,
No, go back.
the jet of the VSD, and one is kind of an aneurysm, but it's not really a true aneurysm. And that measured 7.5 millimeter. So we said, you know, since there's a trivial AR, we thought that let's cross this VSD, see when we deploy a device, what would happen to the AR and to the VSD. So the question I have, Joachim, for you now, what would you advise? So let's show you the angiogram when we crossed with an 8-French sheath. Next angio. Play it, please. So the sheath actually basically is closing the entire defect because this is an 8-French, so about a 3 millimeter, and that's where the opening of the VSD into the right ventricle. So now that's where we are now, and we want your guidance in selecting a device, and what device and what size device you would advise us to use. Joachim?
First of all, I don't exactly agree with the description of the anatomy. The way I measure things, if you can you go back to the first angio, to the previous angio, please, Ziad?
Yes, sure. Let's go back to the first angio.
I mean, at least the one you're showing now with the sheet shows that the orifice on the right ventricle is between, I would say, 3 and 4 millimeters. Do we agree on the right ventricular side?
Yeah.
Okay. The one, I mean, the septal defect to me would be, the way I read it would be, you know, the anatomical septal defect on the LV side is maybe 7 to 8 millimeters.
That's right.
Do you agree, Aziz?
We agree so far.
Good. Okay, no, then it's okay. This morning, Mario elected a muscular VSD device. I personally don't like it so much because I think we're overkilling on the right ventricular side. We don't need to put a big retention disc on the right ventricular side. So I would probably try a 6.4 ADO2 device myself. Honestly, if you ask me candidly, I would say it's a great case for the new device because there's not much aortic rim. But if not, what I would be putting is probably an ADO2 device and pulling it, an ADO1 device, sorry, and pulling it enough so the left ventricular disc, the aortic disc, would be kind of tilted inside the pouch. That's what I would do. I don't know what you do. Think about
ADO. Is John Bass on the panel or in the room?
John must be in the room unless he's for coffee.
Who's on the panel with you?
Well, I'm waiting for the real panel because you guys went online faster than predicted.
You tell me they're having coffee and we are while we're working, right?
I'm doing, yeah. Dieter is here, so if Dieter wants to give an advice.
Dietmar?
I just come in. I have not seen your case, really. I have to find out what you are doing.
So, who's in the micro?
Ziad, this is Evan.
Hi,
Evan.
Hi. I just want to raise the unpopular position at this meeting that I might not do an interventional procedure on this patient.
And tell me why.
Because I think the defect, even if you pull this into the pouch, I think it's going to be very hard for me to envision from the pictures that Aki showed that some portion of the device is not going to sit on the undersurface of the aortic cusp. Aortic valve. And even though I think it'll look great today, I'm a little worried about taking somebody who has such sort of benign hemodynamics and doing something that might ultimately, 10 years from now, cause them to need an aortic valve replacement. So I just wanted to throw that out.
No, I appreciate the honest discussion. We told you about his left ventricle in diastolic dimension with a Z-score of 2.5. So by echo, there is definitely volume overload. So you would not do anything for this patient?
Ziad, I would use an ADO2. I have seen now the VSD, and it is perfect for an ADO2 6 millimeter.
So you will use
very easy to do.
ADO2 6 millimeter?
No block.
Okay.
And I hope we can push a little bit HEA for bigger devices in future instead of the new VSD.
All right.
I'm sorry to say.
Evan, you did not answer my question.
Yeah, sorry, I walked away, but I'm back. No, I actually probably think we would do something as much based on the early prolapse of the aorta as the LV dilation, but something we would probably do would be send them for surgery.
Okay, that's fair. All right.
Well,
so
if I can just, if we assume, Evan, that this kid is a surgical candidate, give it a try in the cath lab. I mean, the worst which can happen is that he ends up with too much aortic insufficiency. You send him to the OR. It's the same operation. They just retrieve your device. It's not bad medicine.
So-
the other thing is, Ziad, I assume you're not having PFM coils.
no, we are not having PFM cores. I don't use them,
Because-
so I'm not familiar with them, so I cannot use them.
Yeah.
Unless if Gianfranco wants to use it.
Just one last comment to answer Joachim, and I don't want to delay the case. And certainly I don't think it's bad medicine to do it. Again, I don't worry about what your result's going to look like today. I actually don't think you're going to have a lot of AR. I guess what's unknown is the device, which is not completely soft, will definitely, in my opinion, be in contact with the aortic cusp.
No,
And
don't open this.
I just don't know what's going to
Let's try the
happen to
file.
that long term, but I'm worried about it.
No,
So,
I think, well,
we're going to proceed, guys. So what my decision and discussion with Gianfranco as well, we are going to use a 5 millimeter membranous VSD device and see how it will sit. You know, obviously there is a fear that it will pull through to the right ventricle. We're going to try this and give it our best shot and go from there. But I think a 5...
wait a second, Ziad.
Yes,
You have the old membranous device.
yes.
Oh, I didn't know that. Okay, go ahead.
So
I don't think this kid is in very much risk of a navy block. He's older. He has an aneurysmal pouch. I think the device is going to be a little bit tilted inside the pouch. I didn't know you had the previous version of the
you are in Italy, my
device.
friend. They have everything here.
Okay. Well,
So-
then it's the best choice.
Okay, thank you.
Available. Oh, Dietmar is.
So what we're going to do, can you zoom on my fingers,
An
please?
ADO2 or an ADO2 AS. But not an old
They know
member.
it. So, yeah. Can you zoom here, please? Zoom. And Gianfranco, rotate the pin vise clockwise. 1 second. Zoom. Clockwise. 1 second.
You go
Now.
without color?
Oops.
I think so.
We're trying to catch it more. Clockwise. Clockwise. More. Stop. So it caught here. We're going to rotate it here all the way, and then I'm going to put it through the capsule. Remember, this is the old system, so come back. Push. Pull.
It's actually not very different from the new system. The new system allows you to rotate your device if you don't
push.
like. But I
wanna
find
see
the old
what's there.
system usually delivered the device in a very good angle
You see
on
it?
the first attempt.
Okay,
so
pull. Yeah. Okay, now tighten the pin vise. Open that, Muhammad. Open it. And pull the cable tight. Good. We all know the mechanism of this device, and now what we're going to do here, we're going to do it under the water seal. And basically, to the end, flush. Okay, good. Like this here, so. All right, so we can proceed with this. Remove this, we're gonna remove this here and allow it to bleed. I'm gonna open this here and we're gonna advance now the entire pusher and cable all the way to the end of the sheath, the tip of the sheath, which you see it on the left ventricle. So here we come, and we are at the end of the sheath. I'm going to do a cine here for you so that you can see it. You see it there? So now we're going to deploy the left ventricle disc.
And just a little detail, Ziad. When you crossed the VSD with your device, the dot was looking to the apex, so you can anticipate that
Yes.
it's going to be perfect.
Yes. So now I'm going to pull the entire assembly to the LV side, and Aki is going to go down and show us how far we are from the septum. And the dot is actually pretty good right there. I'm going to do an angiogram right here to see where we are. You ready? Good. So we are a little bit far, so we have some room. Ahi, can you show them by echo where is the device?
The device sitting, you can see here.
So I'm going to pull back.
You have space. You have distance. Right there. You're on the defect.
Well, I need to see live, guys.
Sorry?
Who's doing? Yeah. No, it was not live. Yeah. So now we came back now, and we are at the septum angio.
Let's.
Is your pigtail entrapped between your device? No.
I'm not worried about that yet.
Yeah.
So we are at and you can see the aortic valve leaflet is moving nicely, actually, not bad. The trivial AR, which was there before, and don't forget we have a catheter.
You have a catheter
Can
through
you play
there.
it, please? Can you play it back? So you can see it there playing back, right?
You can take a look at the echo also. It looks great.
So show them also a big picture on the echo. Big picture on the echo.
Okay,
Perfect.
great. So you
So-
see the device
Go ahead,
sitting
Ahi.
right there, and it's a very trivial AI, but I think it's because you have another catheter across the aortic valve.
Let's go live, fluoro. Okay, so we are there. So what I'm going to do here, let me do the cine and stuff. So what I'm going to do here, yeah, you can leave this here. I'm going to now slide tension and see if I can deploy the device. Oh, it came into the aneurysm actually, which is good. So what I'm going to do here.
That's good. That's good. That's perfect.
Yeah. Angio now for a second.
Stable, it's perfect.
Yeah.
Should we go to 30, huh?
So it seats really nice there. Ahi, big echo picture first.
Can you zoom a little more, Z?
Yes, we can zoom for you.
Because it's a
color
small
down a
device.
little
So.
There is the zooming there. Yep. I'll do a cine for you. There you go. So I think it looks good to me.
Yeah. Let me go just one more view to the 30
Ahi is
degrees.
going to do echo. Show them the echo here, big picture. That looks good. I'm pretty happy with this.
Yep. Looks good.
So the next step is to remove
Just
the
if there is
capsule
any,
from the micro screw of the device. And the way we do it, can you?
Z, just a minute.
Yes.
I'm seeing the EKG of the kid. Can you confirm that the PR interval, everything is normal?
Yes, it's sinus rhythm as I see it there, and the PR interval is normal. Can you show them the EKG on the screen here, please?
Oh, no, Ziad, I trust you.
Okay, fine. So can you zoom on our hand here, please? Can they show our hand? Yes. So this is the pin vise. I'm going to open this here. I'm going to bring it back here. I'm going to open this guy here, and I'm going to fix the cable
It's okay.
and bring the capsule.
Looks sitting great, huh?
Okay, so
Sorry?
it came back. You see it there? That's good. So now we are ready to release the device. Echo, please, one more time, just to
can
confirm
take a
that
look at
everything.
that.
Show them echo.
Yeah.
Echo. Show them echo, please. Echo,
Yeah,
good.
Okay. You see how nicely it sits?
Ahi, go ahead.
Yeah, it sits very nicely. You see both limbs of the device, and
Perfect.
there is no residual leak by echo.
We'll do one more angio before. Can you show them
Sorry.
fluoro? Show them fluoro,
Sorry,
please.
Kamal.
Show them fluoro.
Looks very nice. I was skeptical a little bit.
Can they? Yeah, there you go. We're going to do a
Finish
cine
with,
now.
I thought the right coronary cast
Jack?
is more involved.
That looks good. So I think we're pretty happy, Joachim, with the position and with the location, with everything.
Yeah.
And it's
Okay,
far, to be
and-
honest with
and-
you, from
And
the aortic.
Ziad, you realize that the tip, the left disc of your device is far away from the AV node. So This device was actually great, apart when deployed in the septal defect, and
That's right.
then sometimes we had AV
So we're going to go
block. It
ahead
was
and
a
release
nice
the device. So counterclockwise rotation. I released everything here and bring everything down to the IVC. And now Achi is going to assess by echo everything.
You still have a catheter across the
Yes,
aorta?
we still have a catheter
Okay.
across the aortic valve for the final angio. Let's get 30. 30.
It looks absolutely wonderful. You know, it sits great. There's no more prolapse,
by echo, when
and
we remove it,
the amount of
like-
insufficiency is
Okay,
really minimal.
we're going to do our final angio. Go to fluoro, please. Great, Achi, thank you. And then we'll assess the aortic valve afterwards. Okay, ready?
You can take a look at
30.
three there, the aortic valve after that.
Jack,
120.
Yeah.
beautiful position forming through the device. I think it looks beautiful position. Now we're going to remove the pigtail catheter carefully with a Terumo wire to the ascending aorta and do our final assessment of the aortic valve by TEE. No need to do an angiogram because TEE will assess it much better.
Yes, it's great.
Not touching on the, not interfering.
Yeah,
Yes, I'm listening.
fantastic job.
Thank you.
Fantastic job. But
Thank you.
let us a little bit critical.
Yes, please.
So I appreciate this device,
It's more.
unbelievable. I implanted more than 80 successfully.
Yes.
But we have had 2 patients after 6 months with the AV block.
Yes.
So this device is fantastic. It's fantastically designed and so on. And it's now fantastically implanted too.
Yep.
But on the other hand, when we have to consider the result from the past, then we cannot use it again. Or what is your opinion? So that was the reason why I
Yeah.
offer, would it be possible to close it with the ADO 2 or the ADO 2 IS maybe? The hypothesis should be that we have no risk for the AV block. What is
Yes.
your opinion to this?
So, as you know, I travel a lot, and when I travel outside the US, because the device is still available outside the US, if I have the right patient, i.e., older than about 2 to 3 years of age, I do not have any problem using this device. The incidence of heart block is extremely rare. Now, would I use ADO2 in this case? Yes, you can. The problem, again, you have a longer device to cross the ventricular septum, and the tricuspid valve apparatus may get interfered with. So I prefer to use a shorter device, shorter waist, similar to this device, the membranous device. As Joachim said, maybe ideally, which I don't have experience with, is the new device. But until then, I think in select patients, you can use this device. And of course, we all have to watch for heart block, but I think it's pretty rare incidence in this age group.
Yeah, I agree with you, Ziad. I didn't know you had this device. If not, I would have. It would have been my first choice.
Thank you.
And again, I agree that there were AV blocks in the first series. This patient normally shouldn't. I mean, does not have many risk factors for the AV block issue. Your device is nicely inside the aneurysm. You didn't oversize. It's not a small patient. It was not an inlet extension perimembranous VSD.
That's right.
So I think, but the ADO2AS, I think Dietmar was thinking about the ADO2AS, which is a very short device, 2 millimeters.
He did not
maybe
say
5
AS.
millimeters diameter.
Okay.
This could have been good. You could have tried it also. I don't have
Sure.
experience because I'm doing the new device, but it's also maybe a good alternative. It's a soft device.
Perfect.
It's a
I think
softer
this is a good outcome for this patient. He's in normal sinus rhythm. The echo shows actually no AR. Did you see any AR, guys? So the AR got repaired because we closed the VSD, hoping that now we will protect the aortic valve from this Venturi effect and watch the patient. So before I leave, I want to thank Mario again, Gianfranco and Massimo for inviting me, and the entire team here, the stellar echo team, the nursing team, the technicians, the staff. Thank you, and I hope that you will enjoy the rest of the meeting.
Oh,
Yes,
Ziad, I think Mario is in the microphone.
thank you.
Ziad,
Yes, Mario.
Congratulations, excellent job. We fully agree with you. We did a great job, and
Thank you.
have a nice trip back to the US. Thank you very much.
Thank you so much,
Mario,
guys.
why didn't you tell us this morning that you still had the membranous VSD devices?
Well,
All right.
we have almost everything except the membranous VSD2 that
Yeah.
you're only one in the world to have it.